say that, maybe we can repeat for the people that registered and weren't able to join, or we can send them the videos later and have Q&A sessions for the rest of the week. Once we allow people to go through the materials, and if they, because more than 300 people have already registered for the program. So maybe we can do like a second round of follow-up with all those registered master trainers later.
Yeah, I think around 200 people would be attending in total, including today.
Yes, yes.
And the rest of the
people we have,
and there is live stream on YouTube also. So that's no problem at all.
Yeah. So maybe what we can do is once we finish today's session, maybe early next week within the internal team for RAC, we can have a meeting and see how we can make sure that the rest of the master trainers that may not have been able to join the sessions, but are still willing to continue in their own societies or still would like to do it, we can hold smaller group discussions with them and allow them to go through the materials on their own.
Or they can attend one of the sessions, I think in one of the
live sessions.
Society programs they can attend and see your live stream. I think that will also update them about how to go about it, probably.
Yes, ma'am. I think that's a good idea. Yes.
Yeah, that's a good idea. Yeah.
So
we should start.
Mr. Ajay, yeah. Aparna?
Yes,
start,
Aparna. Can start, I think.
Yes, okay. So a very good afternoon to all of you and welcome to this session on respectful abortion care, which is a collaborative effort of FOXI and WHO India country. This is a one-of-a-kind effort in view of the changed MTP law to not just bring about a knowledge about the changed law, but also emphasize on the correct methods of providing abortion with respect and with privacy. So this particular program today is the third day of the program, and there have been nominated the master trainers who are going to take this program forward in their own societies. So the overview of program is like this, that we have the modules on informing you about the act. Then we have updates on technology, on the methods of abortion. We have then an overview of the WHO Saver Kit toolkit, which talks about providing abortion with respect, safety, along with the rights of the women, pregnant women who are opting for abortion. And then we have a session on pre and post abortion family planning counseling. To begin with the session, I would first like to invite Dr. Pushpa Chaudhary, madam. Can I have her CV, please? Dr. Pushpa Chaudhary, ma'am, is currently the team lead of RMNCH at WHO Country Office, India. She is an obstetrician and gynecologist trained both in India and UK, with over 30 years of experience in clinical, academic, public health, and administration. Dr. Pushpa Chaudhary, ma'am, is the nodal officer behind the launch of this program from the WHO Country Office. Ma'am has been supporting our efforts towards safe motherhood and safe reproductive health among women in India. Pushpa Chaudhary, ma'am, we welcome you to this platform, and we would like you to talk about the concept of respectful abortion care and the need for this program in India at this point in time. Dr. Pushpa Chaudhary, ma'am, please.
Thank you, Dr. Aparna. Good afternoon to all of you, and greetings from WHO Country Office, India. It gives me immense pleasure to be here and start this year with utmost commitment of all the doctors present today, despite your busy schedules. We all know that India has made a historic move to ensure universal access to comprehensive abortion care by amending the Medical Termination of Pregnancy Act of 1971 last year in 2021. Despite the COVID pandemic challenges, the law passed, which is truly a remarkable achievement. With this amendment, India now stands tall amongst countries with highly progressive laws, safeguarding provision of legal abortions on a broad range of therapeutic, eugenic, humanitarian, and social grounds. The new MTP amendment is a milestone which will further empower women, especially those who are vulnerable. It will also contribute significantly towards ending preventable maternal mortality especially Sustainable Development Goals, SDG 3.1, 3.7, and 5.6. While the law expands access to women, the other important aspect is that it has important changes for the providers as well. The law now clearly states that opinion of only one provider for termination of pregnancy up to 20 weeks of gestation, and requirement of opinion of 2 providers for termination of pregnancy between 20 and 24 weeks of gestation. Upper gestation limit not to apply in cases of substantial fetal abnormalities, of course, after being reviewed by medical board. We need to maintain confidentiality, name and other particulars of a woman whose pregnancy has been terminated, not to be revealed except to person authorized by law. And the ground of failure of contraceptive has been extended to women and a partner, safeguarding access to safe abortion based on choice, irrespective of marital status. So for India, this is much needed and welcome step directed towards safety and well-being of women. Given the reality of the country, above all, with the law change, your role as provider becomes even more important in ensuring dignity, autonomy, confidentiality, and justice for women who need and wish to terminate pregnancy. So we have all heard, and we have experienced so far, often the prejudice that provider has for clients that seek abortion. And this is sadly the truth. So sometimes about provider are too much restricted about gestational age limit. Sometimes you have to be practical when your intention is to help the client within the legal limit. I often recollect a young girl of 15 years back in Kathmandu who was declined abortion in my hospital because upper limit of gestation at that time due to rape was only 18 weeks. And unfortunately, she was 20 weeks. I was not provider, but the director of the hospital that time. And I came to know about this case only when the incident was reported to me by one-stop service center staff. So her father was forced to take her to India and got abortion done there, obviously in a private clinic, and spending a lot of money. So you can see, difference between 18 weeks and 20 weeks is very, very marginal in terms of safety of the procedure. And this sort of case could have been discussed with higher authority before declining services altogether. So this gives an example of how provider could be flexible and still, serve within legal limit. So while progress has been made in despite several implementation challenges, we are far from success. 50 years of being legal, unfortunately, unsafe abortion is still the 3rd leading cause of maternal mortality in India. This really needs to change. And as providers, most of you are women. As custodians of safe abortion care, we need to move just beyond safety. We need to adopt respect. And the time is now. So this program, Respectful Abortion Care, is very much linked to respectful maternity care, a concept that was brought forward by WHO. And I'm happy that India has taken a lead in this effort. So adopted from RMC, we have aligned abortion care on the same line. And this is the first kind of effort globally. And India is leading this effort. It refers to care that maintains safety, dignity, respect, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion or termination of pregnancy. So yesterday I recollect there were some questions about why privacy and confidentiality. Simply this is the individual's human health right that any service that is provided has to be confidential and privacy should be ensured. That doesn't mean that you don't need to record these cases. There could be a system that helps you to maintain record as well as to ensure that any information provided to you by your client remains confidential. It's not leaked to someone who is a friend or neighbor. So I'm sure you all know this, but the new act has reinforced the privacy issue of the client. So with this effort of including respect as an integral part of comprehensive abortion care, each one you by becoming master trainers. For your societies, you have an important role to play. Respect begets respect. Because of the significant change in the law, every contact with the provider with you all becomes a pivotal moment in a woman's life. So let no woman, young, old, married, unmarried, or in any situation that may come to you or within your network, feel alone or disrespected. Amendment of Act is not enough. We all need to work together to ensure that respectful abortion care and services are available and accessible to all women, particularly vulnerable groups, including huge cohort of adolescents in India. Foxy and Foxians are key movers and shakers. And I extend my thanks to Dr. Shanta Kumari and congratulate her for advancing this agenda forward. Good luck to you all. We as WHO will be always with you throughout this journey, ensuring RAC to become reality and also to become an example for India, showcase around the world. Thank you very much.
Thank you, ma'am, for those encouraging words and being with us always. And now we move on to the first part of our program. But before that, I would like to acknowledge that Dr. Shanta Kumari ma'am has been leading this program from the front. And this program is historic in the sense that it is first of its kind of a program on respectful abortion care in the country and globally also. As now that more than around 60 master trainers have joined, I would like to also mention the purpose of this workshop is firstly to inform everybody and the people who have joined about the amendments in the Act. The next is to equip everybody with the methods of abortion, which we all know, which we are already doing. But what are the standard methods of abortion which should be provided? But most important aspect of this particular workshop is to talk about respect and dignity of the pregnant women while you're providing the abortion. And also talk about talking to the women, that is counseling. So these are the broad objectives of this workshop. In the last 2 days, we have had attendance of about more than 150 Foxy members who plan to become master trainers for this particular module of respectful abortion care. And including today, the number is going to cross 200. So we do expect a very enthusiastic participation. This is your chance to ask questions, clarify your doubts regarding the changes that have occurred and the path that needs to be taken forward. So with that, I would like to invite the chairperson for the first session, Dr. Krishna Kumari ma'am. Can I have her CV, please? Yes, thank you. So we welcome Dr. Krishna Kumari to this platform. Ma'am has been there with us in the last 2 days, and we are really thankful for her presence today. So ma'am has over 30 years of experience in clinical obs-gynae practice and 25 years of teaching experience. She has been the governing council member of ICOG, national corresponding editor of JOGI, national coordinator for the MEDHA program. She was the president of Obs-Gynae Society of Hyderabad from 2017 to 2019. And she has been the scientific chairperson for the Foxy FIGO International Congress on Clinical Challenges and various other conferences. And she has contribution to various textbooks and journals. So welcome, ma'am, and we request you to take this program forward.
Thank you. Thank you very much, Parna. It was... Is Dr. Bipin joining us?
Ma'am, I think...
No, ma'am, no.
No, okay. So, okay, we'll move ahead with the program. Thank you, Aparna, for that wonderful introduction. And I think all of us are well versed with the MTP Regulation Act. We have been hearing about doing it for such a long time. The purpose of this TOT, as has been explained by Dr. Pushpa and Dr. Aparna, is to know the newer regulations and add the other dimension of how to counsel the patients and do a respectful abortion. I think that this particular dimension is very much well highlighted by the follow-up lectures. And first of all, Aparna is going to introduce to us the most important and most awaited changes that have been the maximum number of questions. Everything would be there in this particular lecture. She is going to give it to us. And this is going to be about the newer regulations that have come up in the recent times, as recent as September 2021. And we all know Aparna, she is one of the young, dynamic additional professors from All India Institute of Medical Sciences. She belongs to the division as of now, working in the division of maternal fetal medicine. And she is a specialist with expertise in fetal interventions. She has been a recipient of many awards like Kamini Rao Orator, Foxy Junior Korean Award, Foxy Sunley IASC International Traveling Fellowship, Imaging Science Committee Award, Rajatre Award in Fetal Medicine, Abdul Kalam Appreciation Award. And she has been the chairperson of AOGD Quality Committee, the Joint Secretary of Society of Fetal Medicine, the North Zone Coordinator for Safe Motherhood for Foxy from 2020 to 2023. She has been the co-convener of Early Pregnancy SIG Indian Fertility Association. She has been, I think she doesn't need any more introduction. All of us, she's so close to all of us, and she's such a, I would call her a very intelligent, hardworking, young, dynamic, additional professor, I should call her right now. All the dais is yours. The podium is yours, I should say.
Thank you, ma'am, and thank you for those kind words.
We are looking forward to your enlightening us about this new act.
Thank you, ma'am. Thank you very much. I hope my screen is visible.
Yeah, it's visible.
Yeah. So a very good evening again, and I'm going to talk about the first part of this module, which is the looking at the MTP Amendment Act. So we will take a closer look at what are the new laws and what are the changes in rules. We all know about the problem of abortion, and it is actually a huge contributor to the mortality and morbidity in young girls and women. 8% of deaths per year are due to abortions, and nearly 2 out of 3 abortions which are performed are considered to be unsafe. And nearly half of the pregnancy-related deaths are in women and girls under 24 years of age. So we do understand that it's a huge problem. When is abortion considered safe? So can we have everybody on mute? Yes, thank you. So according to the WHO, when is abortion considered safe? So abortion is considered safe when it is performed according to the appropriate method by trained persons at a place which is approved for abortion. So when all of these criteria are met, only then it is considered to be safe. And these are some of the things which are already ensured by the Act, but need to be implemented very, very strictly. Now, in 2021, as we all know, in March, the law came into effect, 25th March, and the rules were rolled out on 25th of September 2021. And when we talk about the changes, it is important to go into the depth of each and every change and understand what has changed from previously. So in the previous Act, in terms of the modification in requirement of the provider, it was earlier, we all know, that required opinion of 1 RMP for up to 12 weeks and 2 providers of MTP between 12 to 20 weeks of gestation. But now with the amendment of 2021, we require the opinion of 1 registered practitioner for termination of pregnancy up to 20 weeks and 2 RMPs for termination of pregnancy between 20 to 24 weeks of gestation. Now, why has this amendment come into force? What is the potential outcome is that we will be able to increase the number of facilities, especially in the public sector like PHCs, which are eligible for service provision up to 20 weeks. So this is the reason to increase the access of places which can provide abortion. The next and a very important component is the modification of vulnerable group of women. Now, in the previous Act, the MTP was permissible beyond 20 weeks only for saving the life of the mother. In no other condition was it permissible beyond 20 weeks. However, with the 2021 amendment, there is an upper limit of gestation which has been enhanced from 20 to 24 weeks for special and vulnerable categories of women, which would be defined as violence victims, minors, among others. And it has been done so that the abortion access is improved for the vulnerable women so that they can approach safe and legal abortion services. The next part, and undoubtedly the part which has been most utilized till now and will be utilized, is that regarding to the modifications regarding the birth defects and congenital anomalies. With improvement in the ultrasound technology, the facilities being available, we are detecting more and more anomalies which might not actually have been missed, but these are sometimes even evolving anomalies. So we need to consider both the situation. Now, in the previous act, the act had a provision for termination only up to 20 weeks, whatever the anomaly. But in the 2021 amendment, the upper gestational limit does not apply in cases of pregnancy with substantial fetal abnormalities, which have been approved by a medical board as prescribed under the rules. So if there is an anomaly which the medical board deems to be significantly important, significantly abnormal, then in that case, there is no upper limit. And why this has been done? This has been done to increase the access of safe and legal services for women who seek services late beyond the legal limit of termination for fetuses with significant abnormality. And this has been done to avoid the court cases that have become so frequent for seeking termination beyond 20 weeks. Now, another very important modification related to the marital status. In the previous act, the condition of failure of contraceptive was applicable only to the married woman and her husband. But now, the condition of failure of contraception is to be extended for any woman and her partner. Now, marital status is not of any consequences. And why this has been done? It has been done to increase the access to safe and legal abortion for any woman irrespective of marital status, especially with upcoming changes in the legal age of marriage, which is an important advancement for increasing access to safe abortion. In the previous 2 days, we've had repeated questions on the legality and whether the marital status. So we need to understand that any woman who's more than 18 years of age can have legal and safe abortion irrespective of her marital status. So anybody who's more than 18 years of age is an adult and can seek abortion irrespective of her marital status, and that is the point in this law. The other part is new clause for strengthening privacy. Now, this has been also a topic of a lot of questions, and in this particular act, it is said that the name and the particulars of the woman whose pregnancy is being terminated shall not be revealed except to a person authorized by any law for the time being in force. Now, and also the consent by guardian has been simplified. Now, here I would like to add a few things. So in our hospital also, if a lady is seeking abortion, she is allotted an MTP number, and the admission of that woman is made in the file according to that number with no other particulars being revealed. However, there are certain confidential papers like taking a consent, the need for abortion, and opinion for abortion, for which the names have to be mentioned, and they are actually kept in a confidential manner and not revealed to anybody unless, of course, asked. So these are the things that are important from an implementation point of view also, that the MTP number becomes the ID of the patient, or whatever kind of an ID you're giving, without revealing the name and the details and the particulars. Also, the consent by a guardian implies that you don't need necessarily a parent to be present. You can get an adult whom you trust, any lady or any adult. So a pregnant woman can be accompanied by an adult who's more than 18 years of age and is actually willing to take responsibility to give the consent for abortion. And that is what the meaning here for a guardian is also there. So the importance is that it actually increases the demand for abortion. As we all know, we have been in facilities where abortion is actually stigmatized, and people, and especially the young people, do not feel comfortable coming to the hospital to seek abortion. So all of these things, privacy, confidentiality, have been emphasized so that young people can come to us, seek abortion in a safe and legal manner. And hence the name and the particulars of any woman seeking abortion should be kept confidential except when authorized by law. And the ground of failure of contraception has been extended to woman and her partner. And it has been repeatedly asked that whether the failure of contraception applies to second trimester abortion. Yes, up to 20 weeks, it is all right to accept the ground of failure because it says that it can cause mental agony. So up to 20 weeks, the ground of failure of contraception is allowed. When we talk about the rules under the MTP amendment, so the rules define special and vulnerable category of women to be eligible for extended gestational period between 20 to 24. So here again, we need to understand that 20 to 24 weeks is not a blanket period. There has to be a special and vulnerable category of women, which we will be talking about. The norms of the registered medical practitioner whose opinion is required at different gestational age is also defined. And the rules also specify the powers and functions of the medical boards, which should include a female doctor, an obs-gynae, pediatrician, radiologist when available for each state and mandated to provide timely evidence-based decision. So which are the special category of women who are eligible for MTP between 20 to 24 weeks? So we have the survivors of sexual assault, rape, or incest, women in pregnancy in humanitarian settings or disasters or emergency situations as declared by the government, the change of a marital status during ongoing pregnancy. A woman has a divorce or becomes a widow during this time. Women with physical disabilities with major disability criteria as under the Disability Act. Mentally ill women, including mental retardation, minors. And seventh is the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. So these are the situations in which we can provide MTP between 20 to 24 weeks with the opinion of 2 registered medical practitioners. So this is a special time limit which has been given within this amendment. Now, the question about who can provide. So first of all, one RMP is defined as MBBS or more with any, that is medical practitioner who has assisted 25 cases of MTP, of which 5 have been done independently in a hospital. Medical practitioner who has completed 6 months of house surgency in obs-gynae after MBBS. Medical practitioner who holds a postgraduate or diploma in obs-gynae, and medical practitioner who has an experience of at least 1 year of practice in obs-gynae. Now, this defines one RMP. So up to 20 weeks, one RMP is enough to give an opinion. Between 20 to 24 weeks, 2 RMPs are required to give an opinion that yes, this is a special category of vulnerable women or a fetal malformation, which is major, and this lady can undergo abortion. But beyond 24 weeks, there is a need for a medical board to be constituted, to be approached, that has to give the opinion that yes, this pregnancy needs to terminate it, and or whether this pregnancy needs to be continued. Now, what is the composition of the medical board? So the medical board should have the following suggestive points. The head of the Department of Obs-Gynae for that institution may be the chair of the board. It should have at least 1 woman member, 1 member from the government hospital. Specialists from any other department may be included. So if there is a case of, say, cardiac disorder or fetal neurological abnormality, then the chairman of the board can co-opt the member who would, or the specialist who would be required. And any board member, if not available at that point, may be suitably substituted by other member by the chair. Now here I would like to mention 1 or 2 points. Currently, there are 178 medical boards which are already in function across the country. The list of such boards, according to discussion in the previous 2 days, will be made available on the FOXI website very soon. The boards are state specific, and a person or approaching wanting abortion in a particular state has to approach the state board. In case your state has not yet constituted a board, there is no way that we can provide abortion beyond 24 weeks of gestation without a legal recourse. So for now, we have to either approach the medical boards of the state as they are presently existing. If you do not have a state board a medical board in your state, we do not have any other option beyond 24 weeks. But yes, FOXI, along with the government of India, with support from Dr. Sumita Ghosh, has promised us that they were going to work on this very soon, and all of you will have a list of state boards in your state soon. What is the power of the medical board? It is to allow or deny termination of pregnancy beyond 24 weeks of gestation after due consideration, and ensuring that this procedure would be safe for the woman, and whether the fetal malformation has a substantial risk of being incompatible with life. And we all understand as healthcare providers that the law, although it is very, very flexible, it should be used. The onus is on the gynecologist, on the medical board, to ensure that the mother's life is not at risk and the service is provided with maximum safety to the mother and the baby. And the power of the medical board is that they can co-opt other specialists in the board as and when needed. And as I've been mentioning, FOXI, with the ministry guidance and WHO support, as a part of this respectful abortion care program, they will be helping us in operationalizing the medical boards in the various states by providing information on the website. Also, the function boards are to examine the woman and her reports who would approach the medical board for the termination of pregnancy, and provide the opinion of the board in the Form D. So the board has been formed, they have looked into all of the reports, and then they will decide, okay, this lady needs termination, and they can give the opinion in a legalized format, which is the Form D, with regard to termination within 3 days of receiving the request. So timing also has been taken care of. And also the decision is given within 3 days, and they also have to ensure that the termination is carried out within 5 days of the receipt of the request, because the second trimester abortions, as we all agree, are not that easy to perform. So it is also the responsibility of the medical board, which has decided that this lady needs termination, to ensure that the procedure of termination is carried out with all safety precautions. So we would again reiterate that FOXI has an important role to play in ensuring that there are functional medical boards in every state, and FOXI, under the leadership of Dr. Shanta Kumari ma'am, is working towards providing this information to all FOXI members as soon as possible. So with that, I come to the end of this talk. I would request everybody to put their questions in the chat box, which we will be replying either in the chat box, or maybe can ask the chairpersons to also moderate the answers. So thank you very much, and I'll stop here. I would just end by saying that India is a very, very progressive country when it has come to the legal status of abortion. So abortion is legal. However, it is the responsibility of us healthcare providers to make it safe and respectful, so that women can actually access the care that we are trying to provide to them. Thank you very much.
That was a very wonderful, again, a wonderful and lucid lecture, Aparna, and I think everybody has been updated very well. But I think there are quite a number of questions. Do we have a few minutes to take a few questions?
Yes,
because there have been some questions in the question box. If time permits, we'll go with the
yes, ma'am. I think
few questions can be
yes, ma'am. I think I've taken 16 minutes. I think we can take 5 minutes to take the questions.
Okay, great. So I think 1 second. So it will start off with I think Dr. Hema Patil wants to know if there is any documentation needed for failed contraception.
No, I think this question was there yesterday also. There is no documentation for failed contraception. It is the word of the woman and the husband.
Yeah,
even the woman is enough.
So I think that has been an umbrella under which a lot of couples were included in the last many years also. So coming to the admission file, they are apprehensive that the partner or husband's name and address will also be there on the admission file.
Yes, so that is so it is up to your hospital that the admission number, the name of the lady is not written, but you will need to give some address on that. And as also these files are actually kept in the MRD. So unless it is required by and actually mandated by the law, these things will not come out. So in fact, today only we had a discussion in our hospital on this, that, that because there is no number and the MTP number is only given during the daytime, and later on the admission is made in the name. So there are certain, when you actually start implementing it, there will be challenges, and you can sit with your hospital administration to do it, but this is mandated by the law. So privacy is important. The name has to be there in the consent form. In the consent form, the name will be there. In the opinion form, the name will be there, but in the hospital document, the MTP number has to be there.
Right. And somebody is asking for if there should be a husband's consent. We know that there's no need, but in this extended regulations, any need for husband's consent?
No, ma'am. This is even more important here that, you know, the consent of an adult is required, not the husband, not the guardian, not the parent. So anybody with whom the lady. So here the entire thing is that we have to provide safe care to the pregnant woman, and she can bring along with her any adult who is more than 18 years of age and willing to take the responsibility.
Right. So are there any medical legal implications for minors who come with anybody other than parents? No. Now, she has very clearly said, Aparna has said that anybody can sign. It does need not be a parent.
Yes, but again, with the minor, ma'am, we should always keep in mind the POCSO Act.
Yes,
So,
very true.
So
that is what has to come in mind.
We have to remember POCSO is separate, MTP is separate. MTP does not give you a mandate not to inform. You will provide abortion. Yes, you will provide abortion, but anybody who's a minor has to go through the requirement of the POCSO Act. So inform the law and yet provide respectful abortion. So those two things are separate.
Yeah, so I think this also answers Charmila's query regarding less than 18 and POCSO Act and confidentiality. So somebody suggested a separate admission file has to be maintained. Yes, that is one way of overcoming it. YouTube link will be sent to you. I think it will be available. What to do in a central admission and discharge system?
We are doing that at our place, so it is possible. Please talk to the hospital administration.
Yes, everywhere. All the institutes now have a central administrative system, and all of us, over time, we have made it a little more. It has become more refined.
Yes.
What about OPT register entry and forms or document? Are they necessary to seal and put? Yes.
Yes. So even if you don't seal it, so the register entry, see, admission register entry should not have the name, but the patient's opinion form, that means an OPD card where the patient has come to you for the first time, that has to be written, and then you keep it in a place which is not accessible. So it has to be sealed and sent to the authority if required. But yes, it is not something that can be accessed by everyone.
Right. So age proof, should it be taken in any form of any document? Should be.
So ideally, we are currently using the Aadhaar card as an age proof. If you have an Aadhaar card, then of course we go for it. Unless you have some confusion regarding the age and you think that it's grossly abnormal, then of course we have the other systems to know the age, like the
to reassure that the age is true.
Yeah.
So again, consent of husband has been answered. Any specific consent form for people below 18 years? I mean, for the accompanying person to sign.
Yes. Accompanying person to sign, yes.
Yeah, so it is in the same consent form. There is nothing, no special consent form, I think. Is there a special consent form?
No, there is no special consent form, but the MLC register has to be filled. That is according to your requirement, yes.
Is positive screening for Down syndrome an indication for
not
MTP?
At all. This is
not at all.
If I start on it, that is going to be completely this thing. But no, screening for you have to go for a diagnostic test, of course.
Yeah. So is the board state or district?
So it depends. So as soon as the state boards are actually notified, so it is usually the state boards which are there. There are multiple boards in the state, but the exact implementation will be made known to everybody.
So consent of minor has been already answered. Should the self-MMA and women in shock, can we make it an MLC?
MMA is self-administered medical abortion.
Yeah.
See, medical abortion
is
legal. Yes, medical abortion is legal till the woman is more than 18 years of age.
But so we need not make it. No, if she comes in shock, should we make it an MLC?
See, that is why should you? See, it's an age. She's an adult, right? She's more than 18 years of age. But yes, MTP number should have been taken. So that is something that maybe need to be reported. But I'm not very sure about this, whether it's going to be an MLC or not. No.
Yeah, guardian, for a minor, should we take the ID of the guardian?
The guardian has to sign. The guardian is an adult. So the ID is not needed, but that person needs to be there. Yeah.
Yeah, this is another question which is commonly comes up. Patient takes a termination pills outside on her own. OTC, and then she's coming to us with incomplete or septic abortion, they have asked. So how do we document it? Do we consider it as MTP, or do we put it under the category of incomplete abortion?
Incomplete. I think we take it as an incomplete abortion.
That's exactly. This has been happening since quite some time.
Yes.
By incomplete abortions and miscarriages and all, I don't think they need to be. We don't document them as such as a MTP.
Yes.
Minor among others. I think it's a well-defined. What is a minor is defined very well.
Yes.
OPD register has been asked, accompanying person. I think questions are getting repeated.
Yes. Dr. Astha is again asking, if a patient is not affording any further invasive genetic testing and asks for MTP, then should she be offered MTP? Now, Dr. Astha, I'm going to say it again. See, the screening for Down syndrome is just that. It is screening. So the positive predictive value is very low.
Very low.
If we start providing MTP to everybody who's screened positive, then the purpose of screening is lost. Yes. Please tell them that the detection rate for the only screening is only 70%. So we should not act and provide MTP. This is a very dangerous precedent. Let us not offer termination based on screen positives.
So like you write, the question itself has, it is screening only. It is not diagnostic. So it's that is the difference. It is not confirmatory. So I think there's
one more thing, madam. According to the Government of India guidelines, when we do MTP on a girl who is less than 18 years, we should definitely make a MLC. That's what we do in our hospital, which comes under Usmania Medical College.
Yes, less than 18. Less than 18 is always MLC. Less than 18 is MLC.
It's always MLC. Yes, true. Very true. That is there from the previous. It is not a newer change. Aruna, it has been there from the original act itself.
Can I add, madam? In Kerala, if you don't inform, you will be a doctor will be arrested under POSCO Act.
Yes.
If it is less than 18,
it is mandatory.
Across India. It is across India. POXO needs to be informed. Yes. Ma'am, I think we can.
I think we will stop at this. I think we have covered up to 4:14 p.m. Any questions after that? Aparna, can you please answer it in the
yes, ma'am.
Chat box at a later time?
Yes.
So I think we'll move on to the next session. I would like to thank Shanta and the whole team and for including me and making me a part of this fantastic program. And wish you all the best. We hope that it will go very much deep into our Foxians. Thank you.
Thank you, ma'am.
Over to you, Aparna.
Thank you very much, ma'am, for this session and for conducting the questions. So now we move on to the next session, which is on the safe abortion updates in technology. For this, I would like to invite the chairperson for the session, Dr. Fessy Lewis. Dr. Fessy Lewis is presently the FOXI Vice President for 2021. He is the ISA National Executive Member, Vice Chairperson of the Kerala Chapter of IAG, ICOG Governing Council Member Elect 21-22, and Secretary Kerala Chapter of ISA. He is also the Secretary General for All Kerala Federation of Obs-Gynae. He was the Secretary General and the member for FIGO Reproductive Medicine Core Committee. He has received various awards from FOXI, including the FOXI Korean Kamini Rao Yuva Orator and Imaging Science Award. Dr. Fessy Lewis, we welcome you to this platform and we request you to conduct the session further.
Good afternoon to all of you. Thank you for the nice introduction. I think without wasting time, as we are running late, we will go for the next topic. Next is safe abortion updates in technology, availability of quality of medicines and methods available. And then the speaker designated in introduction is Dr. Suvarna Kaledkar, and as you all know, Madam is the Deputy Secretary General of the FOXI, and also Madam is Professor and Head of the Department of Gynae.
Dr. Fessy, I think let that be,
just
because you know, I'll tell you what, I have to log out immediately after my talk for another webinar. So, you know, I won't have time to even complete my lecture. So I think you can talk about it little later. And I think questions also, whatever in the chat, if after I finish that webinar, I may come back and answer, or Aparna can go ahead with answering those questions. I'm extremely sorry. I think I was supposed to log in at 4 o'clock, but I asked them to postpone that at 4:40 and it is already 4:17. So please excuse me. I must go immediately with the talk. Go ahead with it. I think after the wonderful deliberations at the MTP Act by Dr. Aparna, I'll go with the go on the topic of respectful. Can you see the screen?
Yes, ma'am.
Yes, madam.
And can you hear me also? Yeah.
Yes, madam.
Yeah, so I will go ahead with the module 3, safe abortion updates in technology. And before I proceed with the lecture, I thank the entire team, especially Dr. Shanta Kumari and the WHO team for having me here to speak at this very important session on respectful abortion care. This is the session overview, existing guidelines, pre-abortion assessment, medical methods of abortion, and surgical methods of abortion. These are the WHO global guidelines on safe abortion, the Safe Abortion Clinical Practice Handbook, then Safe Abortion Technical and Policy Guidance for Health Systems. Then we have medical management of abortion guidelines. Then we have health worker roles in providing safe abortion care and post-abortion contraception. And if you see various guidelines that have been being developed since 2012 to 2019, they have passed through several stages. Then another one at 2014, then we have 2015, 2018, and 2019 is the latest. So from going from global to national, if you see this roadmap, the safe abortion guidelines have been adapted to, adaptation of WHO guidelines, and they have adapted to our Indian setting. Now we have this landscape assessment of availability and quality of medical abortion commodity in India 2020. I think if you go on the website, you will get most of these guidelines. If you see the national guidelines on safe abortion by government, and that is the, as I think Aparna has told you, that initially the law changed on 25th of March 2021, and later the rules further changed on 24th of September 2021. And this is the comprehensive care mandated by law. All guidelines have 3 key areas in the management of abortion safely: pre-abortion care, abortion care methods, and aftercare and follow-up. So it includes post-abortion contraception as well as counseling. Now, if you see the decision making, how what all factors are involved, it is depending on the medical history of the patient. If then the physical examination, laboratory investigations, what they are like normal, abnormal, discussing contraceptive options. And if the woman chooses to have an abortion, she should be allowed to choose from among the among the available methods that are appropriate for her based on the duration of her pregnancy and her medical condition. So let us go to the pre-abortion assessment and counseling. The components of this assessment for women seeking first trimester abortion are detailed history taking, general physical and pelvic examination, and laboratory and other investigations, decision making information on abortion procedures, and counseling. So on first visit, the gestational age determination by last menstrual period and physical examination should be carried out. I think this is a revision of whatever we have learned and we have been teaching our juniors all this while, but it is good to revise and understand. So when by 12 weeks, the uterus rises out of the pelvis, by 24 weeks, it comes up to the umbilicus, and the limitations to dating by uterine size on physical examination can be seen here as uterine malformations like fibroid, multiple gestation, marked uterine retroversion, and obesity and molar pregnancy. And uterus that is smaller than expected may indicate that woman is not pregnant at all, or there is an inaccurate menstrual dating, ectopic pregnancy, or abnormal uterine intrauterine pregnancy that is spontaneous or missed abortion. So and if the uterus is larger, then of course we have already discussed that the uterine abnormalities and molar pregnancies could be there. So routine laboratory tests are not a prerequisite for offering abortion services. So tests that may be performed as per individual risk factors on findings of physical examination, pregnancy test if pregnancy is not confirmed earlier, and the hemoglobin or hematocrit is advised for suspected anemia, RH testing where RH immunoglobulin have to be given, HIV testing, counseling, STI screening for, generally that we examine per vaginal examination, that time we come to know and we can do the screening. Other laboratory tests such as indicated by medical history or any other test which are specific to any other symptom or, kidney or liver function test if she has a similar history in past. Ultrasound is not necessary unless to diagnose the pregnancy. Diagnosis of pregnancy is not certain or suspecting ectopic or missed abortion. So here it is underlined that if you don't have ultrasound, don't deny abortion services. If your clinical findings are almost sure and indicating definitely that this is a normal intrauterine pregnancy, ultrasound may not be required. However, in certain cases, it may be required, and in case you don't have it in your center, you can refer the patient for ultrasound and get it done and then offer the abortion services. What about pre-abortion counseling? You have to ask the patient that why you have thought about terminating the pregnancy, the reason for terminating the pregnancy, inform about every aspect of abortion that you are going to perform, that early abortion is safe, importance of a trained provider performing the procedure for safety, available methods of abortion, risks and warning signs associated with abortion method that you must describe, and without contraception, she can get pregnant as soon as 14 days after an abortion, and resumption of her normal activities, including sexual intercourse and any other follow-up care that you may inform her. The informed written consent is important, and decision to accept the post-abortion contraceptive. However, if she is not willing for contraception, she will be provided with the abortion services, irrespective of whether she is denying or she is accepting the contraception. I'm sure those who are working in medical colleges or the juniors, they are firing the patients for, first of all, not using the contraception. Secondly, if they have used and they have come for a failure of contraception, then they will say, if they are not accepting, then they will fire them left and right, and that is not a respectful abortion service, and you must be very polite and gentle with such patients. So clinical management of abortion. The abortion care, if the patient is less than 12 weeks, that is the global recommendation. However, GOI recommendation says medical abortion only until 9 weeks. So 12 weeks or less than 12 weeks, you can use mifepristone or misoprostol. You can use misoprostol only, or you can use vacuum aspiration. If more than 12 weeks, it says global recommendations say that you can use both this mifepristone and misoprostol, but you will do dilatation and evacuation, but dilatation and sharp curettage is not recommended. Whereas GOI recommendation, we are having medical abortion only up to 9 weeks, and up to 7 weeks, that is 49 days, you can give mifepristone 200 oral. After 48 hours, you can give misoprostol 800 sublingual, buccal, vaginal or oral, and similar way for 63 days or beyond 49 weeks. You can give mifepristone 200, wait for 48 hours, 800 milligram misoprostol to be given, either sublingual, buccal, and vaginal, and you expect the abortion to happen. Now, methods of first abortion, trimester abortion, it could be either medical methods, we will refer to as MMA, and surgical methods, that is either MVA, that is manual vacuum aspiration, and EVA is the electrical vacuum aspiration. Now, mifepristone and misoprostol are the tablets, which are, first of all, mifepristone is an antiprogestin which inhibits the action of progesterone, interferes with continuation of pregnancy, An initial oral dose of mifepristone is followed by Misoprostol, which is a prostaglandin E1 analog. Misoprostol causes cervical softening, uterine contractions, and expulsion of the products of conception. Advantages of Misoprostol: it can be, shall we mute everyone? It can be used either in combination with mifepristone or alone. Easy to handle and store, non-invasive, cost-effective, stable at room temperature within its pack, and it can be administered by either oral, vaginal, buccal, or sublingual routes. Reduces the need for skilled surgical abortion providers, equipment, sterilization, and anesthesia. Useful in low resource setting. So wherever the electrical and manual vacuum surgical abortion is not available, we don't have expert abortion providers, this medical abortion is Misoprostol is quite useful. Protocols for this we have just discussed. Day 1, mifepristone administration, that is 200 oral, and then you also give anti-D in case the woman is Rh negative. Day 3, Misoprostol up to 7 weeks, 400, and 2 tablets of 200, and either sublingual, buccal, vaginal, or oral, and 7 to 9 weeks, 800 milligram you can use, and in addition, you may need to give analgesic and antiemetics and offer contraception. Day 15, follow-up day, confirm and ensure completion of procedure, offer contraception if not already done so. So now what are the various characteristics of different routes of Misoprostol? Administration for first trimester abortion, first is oral, that is the pills are to be swallowed. You recommend these oral route up to 7 weeks for first trimester abortion, and side effects like diarrhea, nausea, fever, chills are very well known. Buccal administration is pills are placed between the gums and the cheek and swallowed after 30 minutes. More fever and chills are seen more than the vaginal route. So vaginal route is associated with the lowest rate of side effects. Sublingual route, again, the pills are placed under tongue and swallowed after 30 minutes. There is an increased fever, chills, diarrhea, and vomiting compared to vaginal route. And this is the fastest of action of more onset of action, and highest plasma concentration levels are reached. Vaginal pills are placed high up in the vaginal fornices, that is the deepest portion of vagina, and the woman is instructed to lie down for 30 minutes. You may find pill fragments later, and still it doesn't matter. Most of the absorption would be have done by then, and lowest rate of side effects with vaginal administration. This is just a pictorial diagram. See how the pills are to be kept for buccal. You can see here, and you can see here sublingual where the tongue is elevated, and these 4 tablets are kept under the tongue. So this is the WHO drug regimens dose schedules for medical abortion. The same thing which is just repeated for induced abortion less than 12 weeks medical abortion. First is mifepristone followed by Misoprostol, and then what is recommended is after 2 days and the alternate only Misoprostol can be given, 800 microgram either buccal, pervaginal or sublingual. Now vaginal bleeding for 2 weeks is normal after medical abortion, and such bleeding can last up to 45 days in rare cases. Otherwise the patients then start getting normal menstrual periods after 30 days. Now provision of MMA services. Services should be available at the primary care level with referral systems in place for all the care that for all the required higher level care. Additional services may need to be provided to individuals seeking medical abortion, counseling, testing for sexual transmitted infections, STIs and HIV, abuse support services, Then psychological or social services, it is so very important that you support these women with psychological or social services. Other specialist health or medical services should be made available, and provide them iron tablets for anemia if you think she's anemic and she can improve with oral iron tablets. Then provide any necessary pain medication, provide emotional support if needed. So then what do you do for the follow-up? Follow-up care, routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit after 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, and or address any medical concerns. A routine follow-up visit is recommended only in case of medical abortion using the misoprostol alone to assess the success of abortion. So when you have combination, routine follow-up not necessary, and if only misoprostol, then routine follow-up is advocated after 14 days. So that time what you do, you assess the woman's recovery, ask for any signs and symptoms of ongoing pregnancy. Very important, because sometimes they may say that everything is fine, no bleeding, nothing, but don't be happy, because it could mean that there is any continuation of ongoing pregnancy, the same pregnancy. So review any other available medical records, referral documents, ask about any symptoms since procedure, excessive bleeding, pain, perform a focused physical examination for any complaints, assess the woman's fertility goals and need for contraceptive services if not provided earlier. So to summarize, first visit, day 1, what to do? Tell the physical examination, confirm eligibility, then inform consent, tab mifepristone 200 orally, offer anti-D 50 microgram to RH negative women on day 1. Then tell the woman to come after 2 days. Misoprostol is given, contact address and phone number of the facility or the center where she can go in case of an emergency, record her experience of any side effect on the MMA card, and usually 3% of women may expel completely with mifepristone alone, but misoprostol schedule should be completed. Now, the second visit is day 3, for give misoprostol 400, observe for 4 hours, analgesics like ibuprofen may be given, contraceptive options like condom, hormonal method, oral or injectable should be offered. Then mean period of bleeding is 8 to 13 days. Possible side effects like nausea, vomiting, diarrhea, headache, fever, dizziness, but they are usually self-limiting. So report in cases of excessive bleeding, pain in abdomen, fever, and report if there is no bleeding 24 hours after misoprostol. Consider giving additional dose of misoprostol. So this is the routine. 75% of women abort within 4 to 6 hours of misoprostol administration. Pelvic examination to ensure the completion of abortion on day 15, that is the third visit, and contraception options like hormonal methods, condoms, IUCD or sterilization after 1 menstrual cycle. About immediate return to fertility, you must inform, because they can get pregnant within 15 days, and about immediate about report back if there are any no periods within 6 weeks of completion of the procedure. Ultrasound is required only if examination does not confirm the completion of procedure. Now, these are the side effects. All are mostly self-limiting: nausea, vomiting, diarrhea, infection. Infection has to be confirmed by physical examination and start antibiotics. But if there is a continued pain, you be very, very respectful and take that pain into in a non-judgmental way, and communicate in a non-judgmental way. Verbal support is important, adequate counseling, support the person, give analgesic. And if the pain does not subside, with failure to respond to drugs for several hours, warrant evaluation of other causes such as ectopic infection and incomplete abortion, and admission may be necessary. So in case failure or incomplete result of MMA, then you can offer either vacuum, aspiration or repeat MMA. If incomplete result of MMA, again observe unless there is heavy bleeding, bleeding result, uterus normal size, then abortion is complete. After, or you can repeat the misoprostol, or you can go for surgical method of evacuation. Now, when you observe the patient with query incomplete results of MMA, if the bleeding does not stop and heavy bleeding continues, you cannot just wait and watch. You have to offer the surgical method of evacuation. So excessive bleeding has to be tackled in this way. The woman presents with excessive bleeding more than her menstrual cycle, soaking 2 pads in 1 hour for 2 consecutive hours. You have to alert her, you have to warn her, she has to report. She bleeding decreases over time, no need, then follow the routine care. If bleeding does not decrease over the time, take her vitals, PV examination, POCs in cervical canal possible, digital evacuation should be carried out. If woman is stable and bleeding reduces, again observe, monitor like routine, and for 1 more hour, and then it will be, she can go home. Then USG is indicated if bleeding continues and minimal residual, minimal residual bits are there, then wait and watch. They will get expelled soon. If the POCs and residual bits are quite significant, then women, if suppose stable, again you can repeat a misoprostol 600 microgram oral or 400 microgram sublingual, and vacuum aspiration, if especially if the woman doesn't look all that stable, and you must then immediately conduct the vacuum aspiration. Continuation of pregnancy, vacuum aspiration again. So this is how you take care of excessive bleeding, and this is where the medical abortion is going in disrepute. So we must take every care of every case who faces this heavy bleeding with great care, respect, and passion. Recording and reporting for MMA is just like any other MTP. It does come under purview of MTP Act. The documentation is similar to that required for the vacuum aspiration procedure, and it is mandatory to fill all the forms like Form C, Form 1, that is RMP opinion, Form 2, monthly reporting, Form 3, admission register for the case records. So now let us go to the surgical methods. They are all very well known to us. You have been conducting it time and again. So, but vacuum aspiration is the recommended technique of surgical abortion for a pregnancy up to 12 weeks. So WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curettage. You can see the syringe. I hope all of you are well aware of the parts of the syringe and how it is to be loaded with a vacuum. So these are the valve buttons, the cap release, the collar, which stop retaining the clip, then collar, then the plunger and plunger arms and cylinder base. And these are the easy grip cannulae with a wing base. So these are the handheld aspirators which are used to generate vacuum. And aspirator is attached to cannula of 4 to 12 millimeter in diameter. Usually it is the cannula of the size of the weeks. So 8 mm cannula for 8 weeks, 10 mm cannula for 10 weeks, and cannula can be used in multiple settings, including those even without electricity. So vacuum aspiration can be done even with the electric vacuum aspiration. An electric pump is used to generate vacuum, can accommodate cannula of MVA also with correct size of tubing. If you use a correct tube, then it will work. So cervical priming. It may be considered for women with a pregnancy of any gestational age to prepare the cervix to make it soft and easy to dilate. Recommendations are you can give oral mifepristone 200 milligram in 24 to 48 hours in advance. Misoprostol administered sublingually 2 to 3 hours prior to procedure. Misoprostol 3 hours prior to procedure vaginally, or laminaria tents placed intracervically 6 to 24 hours prior to the procedure. This is the slow method of cervical dilatation, least chances of cervical, the perforation of the uterus, which happens highest, the incidence is at the time of dilatation. Now, important component of quality abortion care, is pain management, and this is very important, and it reduces pain and anxiety and makes the women comfortable. What are they? They are non-pharmacological and pharmacological. So non-pharmacological are very, very important, providing psychological support, explaining each step to the woman in advance, performing the procedure very gently, smoothly, and encouraging the woman to relax and breathe deeply. The pharmacological pain management, you can give any of these anxiolytics, general anesthesia, diazepam 10 milligram orally 1 hour prior to procedure, or IV 2 to 5 milligram 20 minutes prior to procedure. Duration of effect 4 to 6 hours, and disorientation is a well-known side effect of especially intravenous diazepam. Cervical dilatation, for that you need to use a local 10 ml of 1% lignocaine. The effect lasts for 60 to 90 minutes. Again, dizziness, seizures, and gastritis is known. Uterine cramping, both all these NSAIDs can be given 1 hour prior to the procedure, and 400 to 800 milligram. The effect lasts for 4 to 6 hours, and gastritis is quite common. So these are the steps. The step 1 is close the valve buttons, create a vacuum by pulling the plunger, ensure I think those of you who are old timers, we used to have that menstrual regulation syringe. It is the modification of that. So prepare the woman, ensure pain control, ask the woman to empty her bladder, perform cervical antiseptic procedure with cleaning the cervix. Then step 4, administers paracervical block at 4 o'clock, 8 o'clock position. Dilate the cervix, insert the cannula, and use the suction. Vacuum is already created. So when you release the vacuum button, then the suction of the uterine contents will happen. And then you can rotate the cannula in 10 to 2 o'clock position with a smooth, gentle motion. So the key to successful and smooth conduct is being gentle to tissues, being gentle while communicating with the patient, and being soft and respectful. So signs that the uterus is empty, all of us know: red or pink foam without tissue. Then through the cannula, gratis sensation. Cervix, you will find gripping over the cannula. Uterus contracting around the cannula, increased uterine cramping. And step 8, after you take out the tissues, just inspect them. Then concurrent procedures like proceed with contraception. If you are wanting for IUCD insertion, do that, or do a sterilization operation. Instrument processing should be done by soaking it in chlorine solution 0.5%, assists disinfection and helps remove tissue and body fluids. So post-op care, monitor her for any complications, provide management as needed. She may leave the facility when she's stable and meets the criteria for discharge. Ensure that the woman has all necessary information, and document all outcomes of the treatment, including any adverse event, in the facility register and client record card. So this is the aftercare and follow-up. You have to offer her management of abortion complications. So these are the in part of aftercare. Incomplete abortion, infection, bleeding have to be tackled irrespectively. Provision of contraceptive or information, offer contraceptive counseling methods, assessment of any other sexual or reproductive health needs that may require additional care, and no routine follow-up unless meso alone regimen is used. So in summary, India has made historic progress in improving access to safe abortion. Not much has changed in technological update in last decade. As I said, it is just a revision, but I think it's good to revise, good to remember each and every small detail of the procedure. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services, and every client, public or private, give them an opportunity to inform, educate, and equip with proper information on contraception and counseling. Thank you so much.
Thank you, ma'am. And really big thanks to you for being there with us yesterday and today. So Dr. Fessy Lewis, sir.
So with your permission, may I leave? I'm 7 minutes late for the other lecture. So I just leave. Thank you so much for having. Yes.
Thank you for joining. And I really want to appreciate and thank all the faculty
Shanta,
and all the members
I
who have joined for this.
Managed to push in, and push that lecture ahead. So let me leave now quickly. Thank you so much.
I know, I can understand. I'm also in the middle of some
I know. Now you will be throughout this year. Jumping from one webinar to another. Thank you so much, Shanta dear. Bye.
Bye.
Thank you, Suvarna. It was excellent talk. Thank you.
Bye, ma'am. I think we'll go ahead with the next session, no?
We request Dr. Shanta Kumari ma'am to say a few words. She's been able to, ma'am. We are really happy that you've been able to join. So, ma'am, we'd like a few words from you.
Thank you, Aparna and the whole team. I think this Respect for Abortion Care project is going on very well. I would really appreciate all the faculty and all the master trainers who have taken time to join it. Okay, thank you very much. I hope that all of you will be able to take forward this program to your societies. And at the end of the day, the whole country, all the Foxians will be trained in this respectful abortion care. So wish you all the best. And thank you again on behalf of Foxy.
Thank you, ma'am. Thank you for joining. Sir, Dr. Fessy Lewis, before we go on, we'd like to have some comments from you.
I think the madam has elaborated, Swarna elaborated all the points in that. I think we have 2-3 questions. I think you can answer that. I think they had asked about, you had replied also regarding the ibuprofen analgesic, but it is usually regarded that if you take some analgesic, the misoprostol action will be less. Is there anything like that documented? That is one important question, because usually it is a practice to give some analgesics, no?
Yeah, so we generally give some analgesics, and as long as we are giving NSAIDs, generally it is all right. We can give ibuprofen, and paracetamol doesn't really work too much, right? So for a purpose of medical abortion, I think, as we all know, it is all about counseling and telling the patients what to expect. That really works for us. And there are some questions on that too. So we need to tell them what to expect. Yes.
Okay. And there was another question regarding, I think my hospital is recognized for MTP till 12 weeks of pregnancy. As far as now, whether by the revised law, can we do it till 20 weeks?
Yeah, so actually within the rules also, the facilities, so in the primary act also, the facilities which are needed for a 12 weeks to 20 weeks abortions were actually specified. So within these rules also, these are specified, so you need to reapply and take it.
Okay. And regarding the scarred uterus, I think when we use misoprostol, yes, you have to be very careful. But initially, it was told that you cannot use after 14 weeks, but there are some people. But anyhow, you must be cautious with the scarred uterus. That is a basic message, I think.
Yes, we are using misoprostol. We are completely using misoprostol for scarred uterus, but we need to be very careful, have a good backup, have a surgical team ready in case of an abortion. But generally, we are using misoprostol. I think all of us who have had some experience are using misoprostol. Yes.
And one last question, I think, any contraindication for pregnancy with fibroid?
It depends on the size of the fibroid. If you've already become pregnant, if the patient is already pregnant, better to continue. And if it's a very big fibroid and she's come to you in the interconceptional period and you think it's going to end up in abortion, then you do a myomectomy and then conceive. But if she's already conceived, she's pregnant, just manage the fibroid with pregnancy.
Okay, I think as there are no other questions, we will go on with the next session. Thank you for inviting me, and I think this is a very good initiative. I think it must be spread across all the societies so that it will be really useful to all the practicing gynecologists. Thank you.
Thank you very much, sir, for chairing this session, and thank you, Suvarna ma'am, for taking up this particular initiative. So thank you very much. And now we move on to the next session, which would be on the SAVER module, the Safe Abortion Values, Evidence and Respect. For that, can I have the CV of the next chairperson, please? Yes, so for this particular session, I would like to invite Dr. Sampath Kumari ma'am. Can I have her CV? Ma'am, we are really thankful to have you here with us today. Welcome to this platform, and we are really thankful that you have been with us through this program, and it is the support of dynamic individuals like you that is going to take this program across the country. So as we all know, Professor Dr. Sampath Kumari is the chief and head of Muthukumaran Medical College and Research Institute of Chennai. She is the Vice President-elect FOXY 2022. She's the founder secretary of TNFOG and the national correspondent editor for JOGI 21 to 24. She has been the chairperson for the Adolescent Health Committee and also held various prestigious posts, including the governing council member of ICOG. We welcome you, ma'am, here, and we request you to conduct this session.
Thank you, Dr. Aparna. First of all, I thank Dr. Shanta ma'am and the entire team for involving me in this wonderful program. Now we will go with, can I have the CV of Dr. Priya? Yes, Dr. Priya Karna. She is the technical officer for reproductive health at the WHO Country Office for India. She is a medical doctor from Nepal, trained as a public health specialist at the Johns Hopkins Bloomberg School of Public Health. And at the WHO, she leads the Samarath Initiative, Sustain Accelerative Mainstream Access to Reproductive Health, a joint effort with the Ministry of Health and Family Welfare. She has nearly 10 years of experience in the SRHR field, including programs, policies in the United States, Nepal, India, and the 11 member states of WHO Southeast Asia region. Dr. Priya will be talking on WHO Savers Toolkit, Safe Abortion Values, Evidence, and Rights Towards Respectful Bias-Free Services. Dr. Priya, stage is yours.
Thank you so much, ma'am. I do want to just acknowledge, thank you for that lovely introduction. And I'm so happy to see that even today, we have so many participants and such high level of commitment, and really grateful that Dr. Shanta could make it and guide us and share her commitment as well. Once again, thank you to all the master trainers and experts for spending time on a weekend and being present and engaging through the chat box on such an important topic in such a timely manner. I do want to acknowledge that Dr. Meera Upadhyay is also here. She is a colleague and technical officer at the WHO Regional Office for Southeast Asia. And this entire Respectful Abortion Care program, I think Dr. Pushpa Chaudhary had highlighted in her introductory comments. The Respectful Abortion Care program is the first of its kind globally, modeled after respectful maternity care. And together with the Regional Office for Southeast Asia for WHO, we want to be able to create a model that can be scaled up in the whole world. This is the first of its kind initiative. And with the MTP changes, we've talked a lot about what the law is providing, what kind the previous speaker very nicely discussed and revised on the medical and surgical methods of abortion. And before we go into the last session on counseling and communication, I think that it is the right time to introduce concepts of values, evidence, and rights and respect. This is in my session today, we will be, sorry, I hope you can see my screen. In this particular session and module, we will be talking about what is respectful abortion care particularly, what are the WHO standards that we are applying to this, how is it defined, what does it mean in terms of definition, and what it means in terms of simpler, practical day-to-day perspective. We will also examine how norms and stigmas affect services, particularly for abortion, through the WHO SAVER, which is a module on values, evidence, rights. All the materials and presentations that have been shared through experts today are all part of the SAVER toolkit. These are all resources that will be available for all of you all as master trainers, so that you are able to conduct these trainings in your own societies, in your own educational institutes, in whatever manner you would like to implement it, so that not only are you the champions of change, but you can create this entire movement of respectful care in abortion services as well. So let's look at what is respectful abortion care. Like I said, it is a new concept, although we know and have done a lot of work, whether it is in India or from other countries in the world. A lot of work has been done on respectful maternity care using the same principles and definition criteria for respectful maternity care, and applying the same WHO norms. We are trying to advocate for the respectful abortion care program, and you all are the first cohort that is being trained in such a model. This care refers to safety, dignity, confidentiality, freedom from harm and mistreatment, service that enables informed choice, and also provides continuous support during and after all types of abortion. So it does not matter what reason is there for abortion, what type of abortion is there, pre or post abortion. We talked about methods and medical management, pain management. We'll talk about contraception in the next session. But irrespective of the type of abortion, the safety, dignity, and confidentiality aspect, some of which is also guaranteed in India through the MTP amendment of 2021. All of these aspects together form the respectful abortion care. This is what it means in terms of definition. In simpler terms, what does respectful abortion care mean? It simply means that you as a provider or as a client tomorrow, there may be somebody in your family, somebody in your extended network, children, children's friends, anybody. You, whether you are a provider or a patient, should be treated and should treat the other person with dignity and empathy. We all want to be respected. Sometimes we take that for granted, but you have to, and I shouldn't be the one to say this, but then the idea is to reinforce this narrative that respect begets respect. When you treat other people with dignity, with empathy, with compassion, irrespective of the race, ethnicity, gender, or socio-economic status, or even their reproductive history. There could have been many number of pregnancies, miscarriages, age, marital status, unmarried, partner, same-sex relationships. None of this should matter. Patients as well as the providers, they all have the right to have informed consent, refusal, as well as autonomy every step of the way. And as providers, this is our opportunity to make sure that every person that comes to you feels respected. You get the respect that you deserve, but you give the respect that they deserve, irrespective of who they are. Sometimes that means that you might have to speak up against something that isn't right. But that also means that in many, many cases, it's our duty to listen and to support everybody that comes to us, irrespective of whether it is the public or the private sector. In the public sector, it is our duty. In the private sector, we also get reimbursed for these kind of services. Therefore, it should not matter whether it is public, private, age, gender, type of marriage, responsibility. None of these things matter. Every patient, every client is an opportunity for you to exercise respect, not only by giving it, but by also ensuring that you are getting that in that way. We'll watch a short video on what kind of norms and stigma are there in the society, in the culture that we live in India, for example, and how they affect abortion services. I'm just going to share my screen again so that you can see hear the sound. All right. If for any reason you can't, just let me know. And all of these videos will be...
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So I hope that you were able to see through that short video. I mean, these are all things that we know and we've learned so many times over and over again. Many times we must have experienced them in our own personal or professional lives. But the opportunity right now is to just pause and take stock and really go back to the basics and understand that all that we experience, all this social norms around gender, about what sex should be, what reproductive health should be, what men should do, what women should do, what is allowed, what is not allowed, all of these things culminate in disrespect and abuse. This disrespect and abuse can be in many, many forms. If you look at the standard 7 areas that WHO defines as a part of respectful care or identifies as a part of this respectful care, these are the 7 areas. So only when you truly understand what types of disrespect and abuse are there, you can be cognizant and you can start practicing about each, understanding and respecting the rights of women and girls everywhere to address them. We all know about physical abuse, things like slapping, intimidating physically, pushing around. I think we've really moved on from that physical abuse, but many areas, verbal abuse in the form of non-consented care, shouting, screaming, you didn't do this, you didn't do that, why have you come now, why didn't you come earlier, you should have done these. That is also a form of abuse, that is verbal abuse. Sexual abuse, in many cases, it could be there, whether it is abuse of power or taking advantage of a particular situation. And then we also just looked at how stigma and discrimination are also a form of disrespect and abuse. These are some things that I think we've known and we've seen many times. But 3 new domains of disrespect and abuse that WHO identifies as part of respectful care these are something that have come up more recently in the last 2 decades or so. And these are some things that I don't think are either a part of medical education or even practice in the future. Therefore, it's very, very important that as master trainers, as people who will be taking this respectful abortion care forward, we identify and acknowledge that even failure to meet professional standards of care, whether it is not providing proper counseling, not taking the time to listen to a patient, or not building a proper rapport between the woman and her providers, not taking the time to understand what kind of situation might she have been coming to you in terms of when she's coming to seek abortion. Even that is a form of disrespect or abuse. Health systems and conditions and constraints like we have had recently with COVID-19. Basically, the idea is to understand that each time a woman comes to you, that is an opportunity to provide respectful care. There may be many, many different circumstances. It might be a case of seeking services for sexual abuse. It might be under gender-based violence. It might be some kind of family pressure. It might simply be that she needs some kind of support and counseling because she's had a bad or failed relationship from her boyfriend, which is causing her mental health issues. The idea is that each opportunity, that each time we see a patient, we take the time to understand and identify every woman's right from freedom from harm and ill treatment as part of respectful abortion care. Respect, it does not simply mean that you talk nicely, but respect also means that we empower and understand where that other person is coming from. The 12 domains of respectful abortion care. So we move from the definition of respectful abortion care to understanding how norms and stigma lead to disrespect and abuse, to understanding what are the 7 different types of or categories of abuse, things that we are overtly aware of, things that we might not be so overtly aware of, like talking, taking the time to talk. Now we come to how, with the acknowledgement of all of these aspects, how can we imbibe respect in abortion care? What are the 12 things? What are some of the examples of things that you can incorporate in your practice? First of all, being free from harm and mistreatment. No patient deserves to be shouted at, scolded at, told that you did not come on time, you did not do this, you should have done that. No form of physical, mental, social intimidation of any kind is ever acceptable or should be done. Maintaining privacy and confidentiality. This is something that has been safeguarded by law in India. And as custodians of this care, it is our role and responsibility to not only advocate for it, but also uphold privacy and confidentiality. I saw a lot of discussion in the chat about consent forms, who can give consent, who can't give consent. I think the speakers before me very nicely covered what it means for a minor, what it means for a married, unmarried woman. All of those things are very well incorporated in Indian law now. It is up to us to uphold that law. Preserving a woman's dignity and choice. It is not our place to question why or why didn't you do this, or you could have done this, you should have done this, why haven't you done this? It is not our place to be able to question people. Rather, our role and responsibility, really our duty, is to respect and preserve a woman's dignity. We have to engage in effective communication. I think soft skills, listening to the client, trying to validate what they're saying, being mindful of where they're coming from, trying to understand their own circumstances that might have driven them to that kind of service. An abortion can be so personal. It can have so many issues in the future. Maybe she's really sad. Maybe it's not out of choice. Maybe it's really difficult for her. Counseling and making sure that she has that continuous support. It is consensual. It is done free of choice. And you are providing that with utmost quality. I think we won't go into medical management, etc. My previous speaker has very nicely told you all, rather a recap of the kind of services that are available. But we have to also make sure that they are provided in an equitable manner. In the public sector, of course, many of these services are free of charge. Even in the private sector, I think that, so much of effort has gone into making sure that no matter who you are, no matter where you are able to provide that service with equitably. Of course, no amount of quality or respect can be done without competent and motivated providers. It makes me so happy as WHO to partner with Foxy and see all of you all here today. Again, like yesterday, everybody who's been here has taken the time to patiently listen, really understand these aspects. So it shows your motivation already. I'm really looking forward to supporting all of you in taking this work forward and really visualizing this respectful abortion care in your own areas. I think contraception and counseling, no amount of abortion care can be successful without contraception, commodity security, and counseling. My previous speaker already has told you all about it, and the next one will tell you about different aspects of counseling and what can or cannot be done. The purpose of my presentation is really to highlight what are the types of disrespect and abuse, what you should be mindful of, how to remove your own personal biases and your own personal judgment maybe away from the kind of care that you are supposed to provide, and highlight that every patient that comes to you, every time you see somebody is an opportunity to empower and respect the other individual. Towards the same, I think that in the presentation today, you all will get a whole set of short videos similar to the one that I showed you. One is on norms and stigma. We will label and show you all of those things. There is one on how to avoid stigmatizing language, what WHO protocols are. And these are the reason we've converted everything into standardized videos is that you can either share it before people come into training or when you are already doing the training, so that there's more time for dialogue and discussion. I want to show you all that all of these videos are actually a part of a larger toolkit called SAVER, the Safe Abortion Values, Evidence, Rights, and Respect. This toolkit was a global toolkit, again, that we piloted in India with the help of the Association for Gynecologists in Delhi and All India Institute of Medical Sciences, and also the Trained Nursing Association of India. I think that, as you all, as master trainers, take this program forward in your own societies, if there is interest on learning the whole SAVER module, which is really a large 4-week program, do let us know and we would be happy to do it. I'll show you a short video on SAVER.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVER, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVER toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVER has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVER is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So I hope that this was able to give you a flavor of what the entire toolkit is. The video that I showed you on norms and stigma, as well as other videos like the guide to avoiding stigmatizing language, these are all part of the package that you will receive, and this will be available to you to either use in your presentations or give it to people and come for your presentations, or you could even simply just disseminate it to your own students, people that you come across, interns, junior residents, senior residents, totally up to you. As master trainers, the idea is to be able to give you the resources that you need to actually reinforce respectful care again and again, unless and until it becomes an entire movement. I think that the momentum is there. The law has changed. We looked at all the revisions of medical abortion, and not much has changed in terms of technology. But what has really changed is that online trainings like the ones that we are doing now, these webinars, these are all possible. Let's leverage them. Respectful abortion care can reach all providers with all of your support. We know that MMA in uptake has increased, but we also have to realize and make sure that there is no PCP-NDT conflation. We have to learn to respect each individual as they come to us. Their safety and quality, they matter more than ever. And it is through this respectful abortion care program that we hope that you're able to take this forward. I don't need to emphasize this again and again, but then just to recap and end my presentation, the time to strengthen implementation of the MTP amendment is now. The rule for up to 20 weeks of gestation, only one provider is needed. Therefore, your role as in counseling, contraception, referral, compassionate care cannot be understated anymore. 20 to 24 weeks, there are special cases. All of these special cases require sensitivity, judgment-free and timely services. And above all, confidentiality and safety is safeguarded by law. It is one of the only countries in the world that prioritizes safety and confidentiality. We have to be mindful of these aspects. Our social, cultural values, whether it is our own or the client that is coming to us, they are impacted by this. And only when we understand, acknowledge, can we actually empower our clients and even ourselves in providing respectful care. With that, I'd like to play a small game with everybody. I hope that you're able to participate. I want to leave you all with the message that, from 1970s, when abortion was first legalized in India, one of the handful countries globally where it was, we were talking about unsafe abortion. Then in early 2000s, when the first time rules of the MTP amendment were done, we were talking about safe abortion. And it is now 2020. And now it is high time that we all talk about respectful abortion care. India is a global example. It's already made all the legal and mandates as far as possible, as far as law can go. It's now up to us to uphold this and really participate. So I'll quickly play with all of you three questions. I will pose it to you. It's a simple yes or no answer. Feel free to write in the chat box or simply raise your hand to say whether you agree or not. My first question is, according to the WHO, restricting access reduces the number of unsafe abortions. Okay, I see false, no, false, false. Great. So I think we all now understand and agree that WHO does not define what the number of access should be. What WHO does define is safety. When is it considered safe? When is it considered unsafe? As providers and as members of the Obstetrician and Gynecological Society, you all are already the appropriate and trained persons. We went in the previous round about what the appropriate methods are and what appropriate places are. We just have to make sure that we circulate this in a respectful manner. All right, my next question is, MTP amendment requires a minor who's under 18 years of age to get written consent from their parent or guardian before she can undergo a termination of pregnancy. All right, We have yes, true, yes, true, yes, yes, true, yes, false, yes, yes. I think I must say thanks to whoever said false. All right, I can't tell. Okay, Dr. Sharmila, thank you for saying false. I think we had a whole session on this. This statement is false. A minor does not require consent from a parent or guardian. The MTP amendment clearly states, and the mandate for the consent has been so flexible, anybody over the age of 18 can provide consent. This, as providers, should be very, very clear to us. If an 18-year-old is under 18 person is coming and there is no other contraindication or no other nuance associated with this in terms of sexual abuse or anything, anybody over the age of 18 can provide consent for this for this woman or girl who's seeking the service. All of this is very well available in the MTP module 1 that Dr. Aparna took. Please go over it again. We will also share the dedicated MTP amendment law and rules write-up so that they are available to you as resources and you can actually go back and look at it whenever you need. This is my final question. 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it's your responsibility to tell her to continue this pregnancy. False, no, 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 no. All right, I think my job is done. We all agreed that as a provider, it's not our responsibility to tell them what they should or they should not do. It is our responsibility to listen to them, to provide them with the service that they need safely and respectfully. So I think with that, I do want to just highlight and reiterate that in India, abortion is legal. It's up to us to make it safe and respectful. It is up to us to make sure that safe abortion is made respectfully available throughout the health system so that all of Bharat is Samart Bharat, which is our program also. So thank you very much. If there are any questions that I might have missed, I'm happy to answer.
Thank you, Priya. Wonderful talk on WHO Saver Toolkit. So we have talked about the respectful abortion care, how to be done with safety, dignity, and confidentiality. And you have mentioned about the domains of RAC, that is the 12 points, really very, very important. Hope everyone would have enjoyed it. And how to avoid the stigmatizing language. And finally ended with the rules of MTP and the questionnaires. From the answers you got from the delegates, your work is done. I think there is no more questions in the chat box, but some questions Aparna already has answered. Aparna, can you see any questions? I think there is no questions.
No, ma'am. I think we have answered all of
the
questions
everything has
here.
been
And,
Madam, can I just ask a question? It's okay?
Yes, Dr. Bharati.
Thank you, Madam. There is just a question which Dr. Priya just asked us, told us in that in the case of a minor coming for an MTP, anybody above 18 can give consent. It again falls under the clause of the POCSO Act, isn't it? So we need to report it to the POCSO also, along with the consent.
Already,
yes,
it has been told.
So MTP amendment does not say that you don't report it in POCSO. It simply says, so that's what I said. You have to look at all the other nuances and make sure that there are no issues. Reporting is a different thing and service provision is a different thing. I do want to highlight that as WHO, after supporting the government successfully in implementing the MTP amendment, we are taking up certain conflations with PCP and DT. And also there is a huge movement now on increasing the age of marriage to 21 years. So a lot of legal and policy level changes are happening in India, irrespective of the kind of policy or law that might change. It never changes the need for respectful care. And the idea we do, whether it is filling out consent forms, whether it is reporting under different laws or being able to maintain confidentiality, irrespective of all that, we have to make sure that we are safe as providers, but we also provide that safety, that service with safety and with care. Ma'am, if you allow me, with the permission of the chairperson, I'd like to invite Dr. Meera Upadhyay, our technical officer at the regional office, to see if Madam has any comments or would like to say anything.
Yes, Dr. Priya. Dr. Meera is...
I don't know if she's here, but if Meera, if you would like to ask anything or say anything, floor is yours.
She's not here.
All right. I think maybe she's not here, but thank you, everyone. And thank you, ma'am, for the opportunity to present.
I have a question, please. Can I ask a question?
Questions can be put in the chat box, I think.
Okay.
Yes, ma'am.
Just about the POSCO Act, actually, no? Because how will you maintain confidentiality, like when you're informing
Only questions will be answered in the chat box. We'll go to the next session.
Yes, thank you, ma'am.
Thank you.
But just about the POXO, we mentioned repeatedly, POXO is an independent entity. You have to inform the police. And the police is authorized by law. So information under POXO is given to the authorities of the law. It is not a general information for general public. So that information has to be registered as an MLC case, and all of those necessities have to be done. But when this patient is an inpatient and requiring MTP, on her admission file, you will write the MLC or the MTP number. There you don't write the name. But on the consent form, on the MLC register, which goes to the police, you will write everything.
Write the name.
Yeah, and with that, I would like to now, let's move on to the next session, and we'll have the answers in the chat box for any further questions. So thank you, Priya, and thank you, Dr. Sampath Kumari ma'am, for the session here. And with that, I'd like to welcome our dynamic chairperson for the next session, Dr. Nandita Palshetkar ma'am. Can I have her CV, please? Dr. Nandita ma'am does not need any introduction. She's an eminent IVF specialist with more than 30 years of experience, medical director of the Bloom IVF, and specialized in ART from the world famous centers across Belgium, Melbourne, and Copenhagen. She has been a pioneer in India for the latest technologies in IVF. She's a PG teacher, delivered more than 65 orations. She has been the Foxy president, revolutionary Foxy president in 2019, and she has also headed various other societies like MOGS, MOGS, IAG. She has been the member of SSB for the PCPNDT committee and various other important work she has done with respect to the ART bill, PCPNDT committee, the Manyata project, and she received innumerable awards. Ma'am, it is really our honor to have you here on this platform, and we would like to hear from you.
Thank you, Aparna. Thank you for inviting me here. And at the onset, I would like to say that I think Foxy for All always has been a fantastic motto which Dr. Shantakumari has launched. And this initiative to provide women with the safe and quality abortion care, I think, is an amazing TOT program of respectful abortion care in collaboration with WHO. I think this was the need of the hour. So far, we have always talked about respectful maternal care, respect during labor, and I think this was really, really lacking. Respectful abortion care is something that was very important. It is all for the holistic approach towards women's health, taking care of both, physical and mental health. And also, remember that it also empowers the women. I mean, I have seen that the respect, the dignity that we give really empowers it. And of course, the skill enhancement of the healthcare providers, which improves the abortion safety with respect to, and also the contraceptive counseling is so very important, using evidence-based, innovative methods to minimize the complications. I think this whole TOT, which is, organized in that way, is really very important because it improves the health system at each and every level, like providing quality care, availability of skilled healthcare workers, good referral system, and to create awareness regarding the new MTP laws and safeguarding the rights of women. So understanding and improving the skill in RAC, we can actually build a trust confidence level with the women of a country. This is to ensure that this woman has complete faith in you. You give her a complete, non-judgmental treatment so that she can come back to us and absolutely not hesitate in coming back to us and asking us questions. And so really, I welcome all of you all to this seminar and hope that we can gain a lot out of it. A beautiful lecture by Priya, and I'm sure the next speaker, Parikshit, is really going to educate us on the post-abortal care, which is so very important. And I think I just want to say happy learning to everybody. That is the essence of FOXY, where we translate our knowledge into healthcare for the women of our country. Thank you. Thank you very much, Aruna, for ensuring that I'm here on time and being so careful about everything that is going on. And good to see very good friends. I think Vidya, Ajay just sent me this, and I think Ramni was there, and Sampath, and a lot of others. Charmila is here. Aparna, thank you so much. Good to see you when you work so hard during my year. Thank you. Thank you very much. And will you please introduce Parikshit? Because I'm on the mobile, so I can't read the CV.
Yes, ma'am. I will do that. Thank you so much, ma'am. Thank you for joining us. With that, a few words from Dr. Nandita, ma'am. Ma'am, it's really my pleasure to hear you. Your inspiring words always motivate us to do more. Thank you, ma'am, for joining us. The speaker for the next talk is Dr. Parikshit Tank. He is a consultant at Ashwini Maternity and Surgical Hospital and also consultant at Jupiter Hospital, Thane. He's an honorary professor for the Pacific Medical College, Udaipur, and he's a consultant for the assisted reproduction at 16 centers. He's the treasurer for FOXY, chairperson of the Safe Motherhood Committee, postgraduate teacher and examiner for the MRCOG Part 3, and the managing committee member of the Mumbai Obs-Gynae Society. He has received many awards from FOXY, and we all know that he's a dedicated worker and a great teacher. Dr. Parikshit, sir.
Much, Aparna. Pleasure to be a part of today's program, and for that I must thank you for all the work that you've put in making these modules. It's really fantastic. The entire FOXY team, especially Dr. Shanta Kumari, Dr. Patel, the General Secretary, Aruna Suman, immense amount of work has gone into creating these modules and making the program. And of course, all the technical inputs which have come in from the WHO team. I must particularly thank Dr. Chaudhary, Dr. Priya Karna, and Dr. Agarwal for all the great work which has gone into making this module possible, this training of trainers possible. So I'm going to talk about pre and post-abortion family planning counseling and how we can optimize this part of the entire delivery system. So what's counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to an open sharing of thoughts, feelings, and perceptions. So, each and every aspect, each and every phrase of this definition has great meaning, really. And unfortunately, we don't have the luxury of time to explore the nuances of this, but a lot has been conveyed in the talk which Dr. Priya just gave, where it has been made abundantly clear that the cornerstone, really, of respectful abortion care is good counseling. Without that, where are we? Unless we are able to communicate and have a clear dialogue, we are not going to get anywhere with a respectful provision of services. So, counseling is an integral part of the comprehensive abortion process. It's as important as the procedure, really. And it helps women come to decisions which are going to affect their short-term and long-term reproductive health. And it should be inclusive. It should involve her partner as and when the need arises. What would be this counseling entail? What does it entail? It allows the provider to help the woman to decide. Sometimes the woman is not decided when she reaches a provider whether she should terminate or she may continue. So how do we help to come to that decision? How to help her to choose the method of termination, ensure that she receives that entire package of a comprehensive delivery. And ultimately, we want to also leave her with a good contraceptive method, which will ensure a good long-term reproductive health for her. So this pre-procedure counseling, just the basics are extremely vital here. Privacy and confidentiality is something which is ensured in law, but the rest of it is not. That's up to the provider. And being non-judgmental, establishing a rapport, using language which is simple to follow, and ultimately, assessing how the process has gone. That's what the counseling is all about. The importance or the relevance of family planning in this context of the abortion occurring is the fact that there's a quick return to fertility. It's an opportunity for us to include this woman with contraceptive acceptance, discuss health benefits of certain methods, and allow her to space when she should have the next pregnancy. And as they say, 90% of abortion-related maternal mortality can be prevented if we ensure that there is effective contraception. So when does this counseling about family planning start? It starts at the first contact, at the first consultation. What to counsel about, the importance, why she needs it, what type of choices are there, how to arrive at a decision, then go into the details about a particular method and discuss high-risk behaviors as they may apply to the particular situation. All said and done, and this has been said before too, that if a woman is not willing to adopt any contraceptive method, please don't make that as a bar or a barrier to refuse termination of pregnancy in that given circumstance. And we need to try and counsel her to educate regarding this process. And if she's not willing at that time, extend the time period, allow her to come back with a decision after some time as well. So assess the general suitability in terms of ensuring that the process is complete, there are no complications, and a fresh pregnancy has been ruled out. Post-procedure counseling should include the precautions that a woman needs to take in terms of her general health, and again, an opportunity for contraception. The counseling should be a continuous process to ensure that there's a privacy and confidentiality, reassure her in case that there are problems, that there is help available, and repeat the information so that it gets reinforced about the post-procedure care and the danger signs. So if a woman has already opted for a mode of contraception, then we need to appreciate the fact that she has been able to arrive at a decision, start off with the method in the appropriate manner, if it's an IUCD or a depot injection, ongoing if it's pills, and the follow-up protocol needs to be talked about. If she's undecided, then this is an opportunity to talk to her to allay her anxiety, talk about the importance of the immediate need, as I discussed earlier, that the period of adoption can be extended, couple unit can be counseled together, and provide emergency contraceptive pills if the couple is still not willing to accept. So going through the various methods very quickly, if we are talking about barrier contraception, condoms, then after a first trimester abortion or a second trimester abortion, they need to be used as soon as sexual activity resumes, because ovulation can occur in a very short time after an abortion has happened. And of course, we know all the additional information which goes with barrier contraception, that it doesn't have any hormonal effects, it's easily available, and it also protects women and men against sexually transmitted infections, including HIV, and allows men to participate in the responsibility of contraception. If we are talking about intrauterine devices, after a first trimester abortion, which has been done surgically, then it can be done along with the procedure or within 12 days of confirmation that it's complete. If it's a medical abortion, then inserted around day 15 of the process after ensuring that it's a complete process. If it's a second trimester, along with the procedure or within 12 days, provided the other contraindications have been ruled out. And we all know that IUCD as a contraceptive measure is highly effective. It's a single time intervention. A wide variety of care providers can do this for the woman, and there's an immediate return to fertility once it's removed. If we are talking about combined oral contraceptive pills after a surgical procedure, start immediately or up to 7 days of a surgical procedure. If it's a medical procedure, then start on the day that you give the Misoprostol. That's traditionally taken as day 3 or within 15 days of the process of confirming that it's a complete abortion. If it's second trimester, then immediately or up to 7 days. And we all know the health benefits that the combined oral contraceptives can provide. Of course, one needs to deal with some of the myths and the rumors that go along with pill prescriptions, and this becomes important. MPA, Depo-Provera, immediately or up to 7 days after a surgical procedure. And if it's medical, then on day 3, along with the dose of Misoprostol. Second trimester, immediately or up to 7 days after abortion. Again, a simple method which a wide variety of providers can incorporate into their services, which they provide to women. Highly private, confidential, very, very effective. And of course, it needs to be done with counseling that there can be some menstrual irregularities with progesterone methods. If the couple is at a stage in their lives and they are prepared for permanent methods, then female sterilization can be performed after an abortion in the absence of any infection or severe blood loss. Concurrently with a first trimester, both you can do a mini lap or a laparoscopic sterilization. If it's a medical method, then after the first menstrual cycle. If it is a second trimester, then mini laparotomy sterilization is advised. Laparoscopic sterilization is not recommended. And of course, a vasectomy can be done at any point in time. It really does not have anything much to do with the abortion provision. So just a quick chart to highlight a few words about teleconsultation and the use of technology. We've all seen remarkable changes what providers and the clients have undergone in leveraging this technology in terms of consultation, counseling, guidance, references, and linkages. Each and every aspect of our services can be leveraged. There are wonderful sites and social media which is available, especially Ask Tanu is a bot which answers questions about contraception. And then, of course, we can point our clients to the right direction, to the right information by telling them about education platforms which the WHO, the Ministry of Health and Family Welfare, FOXI, RCOG, all these sites have very good authentic information which the couple can access. The strength is, of course, that we've gotten used to it in the COVID era. It's approachable, there's awareness. The weakness is that face-to-face is irreplaceable, of course, and demonstration of certain aspects is not possible. It's a great opportunity, but the problem is, of course, that if you miss a diagnosis, then it can have some serious clinical implications. So the key messages, again, I would like to quickly recap that there is a great need for peri-abortion family planning services and counseling about it. And we should strive for maximum coverage, strive for 100% coverage of these contraceptive services. And adolescent reproductive health needs to be both online and offline. So thank you very much. Once again, I would reiterate the thanks that I have made, and it's especially great to have Dr. Palshitkar as a chairperson. She's busy to go to another meeting, I think, but it's great to see you, ma'am.
No, Parikshit, that was so beautifully told and so lucid and absolutely correct. What I really appreciate is you talking about the counseling, pre-counseling, where you actually talk about not only the procedure, but also their, the contraceptive need. I think that is the right time. They're vulnerable that time, and they accept this advice very beautifully. And also the other point which I liked in your lecture is that if she's already taking it, appreciate that she's taking it. I think those are very valid points which will make the woman, I think, respectful abortion care. I think that is what the whole ethos of the whole thing is, and beautifully taken lecture. Thank you very much. I don't know if there are any questions.
Thank you.
Aparna, are there any questions?
That respectful, it kind of hits the nail on the head.
Absolutely.
With the communication which goes along with the whole process.
Ma'am, there are no questions, just a few comments that, people are using medical methods as methods of contraception, and people are not ready to accept any type of contraception. So, Dr. Parikshit, ma'am, what do you want to say about this?
My answer to that is, so what? It's still better than an unsafe abortion, and the mortality is going to be still lower than maternal mortality. So, of course, it's not the ideal kind of a circumstances. We need to address, see, these are once in a while exceptional kind of couples who will be doing this. So we need to broaden our counseling. We need to expand, we need to explore why they are doing that. There would be some reason or the other why they have the hesitancy of adopting an effective contraceptive method. And I think with an empathetic ear, there's often a conversion of the non-believers.
I think, Aparna, also awareness and spreading and reaching out to them. I think that awareness is very, very important, and reaching out to them and convincing, we have to reach really the lowest part. So talking to people, training all our people, this kind of training is very, very important. And what I'm very happy about is that whatever policies we actually make on a national level, they are the same all over the world. So WHO contributing to it is good, because different things about different countries, and some of them may be applicable even to us, so it's really wonderful that we are doing this.
Very true, ma'am. Very important points about awareness. And as Dr. Parikshit said, unsafe abortion is not an option. So even if they're refusing contraception and they're going to be one rare couple who's doing that, and awareness is the key, that we need to keep counseling them, and maybe they don't know the whole thing, and that is why these things are happening. So thank you very much, ma'am, Dr. Nandita ma'am and Dr. Parikshit. Thanks, sir, for being here and making this session so interesting. And I'm sure all of us are really charged up to take this program forward. Thank you very much. And with that, we come to the next session. And for that, I would like to invite Mr. Ajay. Can we have his CV, please? I must mention that Mr. Ajay has been the pivot behind which, the entire program has been evolving, right from, the planning to the execution. And, as you can see, 3 days of, marathon, launch of this program, and then more than 200 people being trained as master trainers, and a plan in place to actually take this across country. So I would like to invite Mr. Ajay Bharadwaj, who's the founder member of the Avni Health Foundation, which is an NGO, and he has focused on, contributing towards business sector, corporate management, and also public health and development sector. So most of his worked across 21 states in India and also internationally, and he has been behind several successful programs in India, like EMOC, PPIUCD, PPT, CT, MDR, and stillbirth and Dhira. So, Mr. Ajay, we would like to know from you, because, there are many questions. People are all charged up. They want to know how they can do it in their societies, how we can help them, and what are the next steps. So we are all, ears to hear to you.
Thank you so much, Aparna, for this, wonderful introduction. And, it's, as you rightly pointed out, for everyone's benefit, this is the 3rd day in a row that we are doing this. And I must really appreciate the enthusiasm of each and every faculty member here who's done this repeatedly for 3 days. Okay. It's like, you eat the first sweet, okay? And after that, you eat the second sweet. It's not that the second chocolate or the second sweet is less sweeter. It's just that, the first one has masked the taste so much so and with the enthusiasm that each one is repeatedly talking about the same thing for 3 continuous days. Hats off to all of you all, for making this happen and so successfully doing it. And Priya and Aparna, an important message for the two of you. The reward for doing good work is more work. Okay, so be ready. As soon as the session ends, you will be receiving an email from me to take this process to the next step, and some more aspects to talk about. With that, let me talk to you about the aspect related to the operational plan, which is absolutely critical for all of us to understand. Just to get all of us on the same page as to what we are trying to do here, apart from the technical part, we are looking at a goal of reaching all the 262 plus societies, where each one of you will be playing a critical and major role, through which we will be reaching out to all the Foxians, which is 37,000 members, and you will be taking the process forward. And 500 master trainers are going to be trained in this program. Almost 250 of you have been trained between last 2 days and including today itself. There's an email here, foxy.ractraining2021@gmail.com is the best way to communicate to us, because we have a dedicated team who will be responding to all your queries. WhatsApp is great, but usually we do not, would like to encourage that, because there are too many things happening. And given that, if 37,000 members start writing to us about what needs to be done and how it needs to be done, it's going to be completely challenging for us. About the training session itself, each society will be expected to hold an RAC online training program, through which we will be orienting all the Foxy members, and this needs to be completed between February and April of 2022. The PPTs, some of you have seen, I've seen the chat box, some of you have been asking for it. Yes, they are ready, as you can see, and they will be given to you by us. No changes, additions, or deletions are allowed in the slides. You have to use them as is. You can introduce yourself verbally before starting your session. Do not add any slide for the same. Once the training session date and time is fixed, let us know by email. We will, there are 2 ways to do it. We will either arrange a training master trainer for you to conduct the session for you or the topics for you, or, you can choose your own master trainer from your society, someone who has been trained by us through these sessions that we are holding now. And 2 trainers are expected to be completing the training program as we go forward and scale it up in your respective societies. Sorry. Running of the training session, we will be allocating 1 national observer for your session, who would be trying to tie it up for you and supporting you. Please adhere to the topic time which has been allotted. No change in the topic sequence as per the agenda will be allowed. We need to follow the same sequence. Do allow time for taking questions and have some discussions, as you have seen it today. Ensure you keep informing at the completion of every topic that registration and pre-test, which you have already completed, and that's the reason why you are here in the program today, followed by the post-test and feedback, because all of these 4, along with your participation and attendance in the program, are important for receiving a certification. Honorariums have been allocated for individuals, as well as, I'm happy to inform you, for your respective societies as well, who participate and takes this program full-fledgedly forward. The Zoom, you need to fix, as I said, your date and time for your program and inform us. A Zoom link will be sent to you, which will be the invitation, which you can share it with your fellow Foxians in your society. And the Zoom link, as you've seen today, has got the registration and pre-test, both of which are compulsory before somebody can join this program. And once the registration and pre-test, which will be shared with you in advance, you need to complete the training program, and at the end of the training program is when the post-test and the feedback will also come up on your screen, just as it will do today, and the participants will be expected to solve that. So these 4 things: registration, pre-test, post-test, feedback, and your participation and attendance. These 5 things are critical for yourself, as well as when you take the sessions going forward, for every participant to be eligible for the certification. You have to, we will send you the link. You download the presentations and keep it with you. And you have to use your own, these very presentations and share your screen. Screen sharing will be allowed by us for you to take the process forward. Lastly, registration and pre-test are compulsory, which is the reason why you are here. Post-test and feedback are critical, which will happen at the end of the session. And these are critical for you to submit for the certification to be delivered to you. Now, when you are going to leave this meeting today, when the meeting ends, you will get a pop-up. That means something will come up on your screen, which will have 2 tabs. The first tab will say continue. The second tab will say exit Zoom. Please do not click on exit Zoom, because the moment you click on exit Zoom, you will not get access to the post-test and feedback. Please click continue. The moment you click continue, you will be taken to the post-test and feedback, which is what you need to submit. Okay. For those who may have some internet issue and are not able to, click either continue or whatever, and do not get the post-test and feedback, do not worry. We will have a list of all such individuals who have not submitted their post-test and feedback, and we will send you one-on-one email for you to click on the link there and submit that, so that you do not lose out on your certification. I hope all of this is clear. And if you have any questions, we are happy to take them in the chat box. Otherwise, we are good to go. Thank you very much for a patient hearing. Being a Saturday evening, it's so nice to see the stickiness of this program, that all 57, 60 people are continuing to be part of hearing what we have to say. Thank you so much, Aparna.
Thank you, Mr. Ajay. And I think the process and the next steps are very, very clear. If you have any further doubts, you can mail to the mail ID, which has been previously shown. So with that, we come to the end of the 3rd day of training. And before I end, there are a few things Dr. Aruna was saying, just a concluding comment. So I told her I've been commenting the whole time, but just to, end it, I would like to say that, all of you are going to be the master trainers with a responsibility to take this program forward. As mentioned already, you will be provided with the modules, guidance, and even speakers if you want to. But most importantly, there are 4 things that I would like to say. First of all is know the act. So very important, know the act, understand it for yourself. The second is act on the act yourself. When you are providing abortion, do it yourself. And the third is respect the act. Please respect the provisions under the act. They have been made after 20 years of deliberation. There is some thought given to it. And the fourth is respect the woman. These are the 4 things that are actually very important take-home messages after this workshop. And I would like to say that Government of India has given us a very liberal law. Let us allow the woman to benefit from this law, and that can only happen if we are able to get over our biases. Married, unmarried, young, old, first abortion, 4th abortion, taking contraception, not taking contraception, all of these are not a criteria. The only criteria is she wants abortion, we provide abortion. So if we are, as master trainers, we do it in our daily lives, we will be the true master trainers by actually living by example. So with that, I would like to conclude the session for today, and a vote of thanks is due, starting with Dr. Shanta Kumari ma'am for taking this historic program forward, Dr. Aruna Suman ma'am for conducting this program, anchoring this program for the whole 3 days, and the whole team of Dr. Shanta Kumari, WHO Country Office India, Dr. Pushpa Chaudhary and Priya, who have been really taking this program forward for the country, for the women of the country. Of course, all the faculty and chairpersons, some of whom have been with us for all of the 3 days. So thank you very much for being with us and really giving your inputs to this program. And all the master trainers who have knowingly or unknowingly taken up this responsibility, and now we are not going to leave them. So thank you all for being here today. And also Mr. Ajay and the whole backend team for doing this so seamlessly for the 3 whole days. So thank you very much. We will be in touch and we will make you do the rest of the things. Thank you very much. A very good evening to all of you and a happy weekend. Thank you.
Thank you, everyone. It was a wonderful program. Yes.
Thank you.
Thank you, everyone. Bye-bye. Have a good rest of the
Thank you,
weekend.
Aruna. Thank you.
Thank you, ma'am. Thank you for being with us. Thank you so much.
Srima,
Thank you, Priya.
Just don't close the meeting. Keep it open for another 10-15 minutes so that people can submit their post-tests and feedback. Thank you.
Sir. Okay, sir.
Bye.
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 Thank you. Excellent program. And sure, Dr. Aparna, we will be with you. We will not leave you. And we have all enjoyed the program and happy to be in such a good program where we can do good to the women of our country.
Gurpreet, you have not yet left the session. How will you get the post-test and feedback?
No, I am also there from the Aurangabad Vijay Society.
Yeah.
We will definitely carry forward this program. Definitely.
Gurpreet Batra, I don't know if you heard me.
You have to leave the meeting,
program
then the message will pop up. Yeah.
Do we have to leave the meeting? Do we
No, we don't have to leave, no. We have to
we
continue.
don't leave.
No. We have to click the leave, then the message will pop up. That's what Jay told.
First, we will have to leave the meeting.
Thank you so much.
Yes, Anjali.
Have we to leave the meeting first, no?
Yes.
You have to click on the leave, the message will pop up.
Yes, thank you.
Thank you so much for somebody helping me out.
Thank you.
Yes,
We didn't want to leave the meeting.
Very enlightening also. Learning so many new things today.
I am from Satara and I would like to carry forward this program.
How will I get that feedback questions? I have to leave from here?
You have to leave the meeting, sir. After that, you'll get the link, sir. If you wait for 2 minutes, you'll get a pop-up. Then you have to fill everything and you have to submit, sir.
Before this, I left, so I got exited. So
there's a leave button at the right side, and the down.
There is one option coming, give feedback. Do we have to click on that?
Sorry, madam, I didn't get you what you said.
Yeah, actually, when I click leave meeting, there is one
Yes, ma'am.
option coming below that, that is give feedback. Do we have to click on that?
Yes, ma'am. You'll get a pop-up, right? You just click on that. You'll
No,
get.
I'm not getting anything.
Okay,
I think
ma'am. If you're not getting, then we'll send a mail to, sorry, link to your mail ID, madam. You'll get the link.
Okay.
You just fill it and you submit us.
Okay.
Okay, thank you.
The pop-up will appear after 2 minutes, sir.
Yes, madam.
Pop-up will appear after 2 minutes, sir.
Yeah, it takes some time, madam, like 1 minute or 2 minutes
Okay, sir.
after you
Thank
leave. Okay, ma'am. Welcome,
Thank
ma'am.
you, sir.
Welcome, ma'am.
In Zoom, please leave the meeting. After that, you will receive on a pop-up, ma'am.